Good afternoon, everyone. We will get the webinar started in just a moment. We'll let everybody kind of get settled in the virtual room here. So please be patient. Okay, it looks like we are somewhat stable on our attendee list. So we will start the webinar. Good afternoon, everyone. My name is Dr. Eric Toring. I'm the Executive Vice President for the American College of Veterinary Preventive Medicine, and I want to welcome you to the webinar today. The webinar is sponsored by the American College of Veterinary Preventive Medicine and its partner organizations, the U.S. Animal Health Association, the National Association of Federal Veterinarians, the American Association of Food Safety and Public Health Veterinarians, and the National Association of State Public Health Veterinarians. Before we turn it over to our speaker today, I wanted to make a few administrative announcements. First of all, this session has been granted up to 1 hour of RACE-approved continuing education. To to earn a CE certificate, an attendee must attend for a minimum of 50 minutes. Those CE certificates will be sent out to attendees that earn the certificate in approximately 1 week. If you used a telephone to dial in, if you dialed the telephone number to join this webinar, we would ask that you send an email to EVP, that's Executive Vice President, at acvpm.com. EVP at acvpm.com, or I'm sorry, I made a mistake. EVP at acvpm.org, O-R-G. Send me an email with your name and your telephone number, and that way I can match your name with an attendee and get you that CE certificate. I'll repeat this announcement at the end of today's webinar. We will offer an opportunity to ask questions of our speaker today. If you do have a question, please type it into the Q&A feature of Zoom, and after the presentation, we will pose those questions to our speaker. So without further ado, I would like to introduce our guest speaker today. Dr. Erica Tremuta-Drobness is the CEO and founder of the ELTD One Health Consulting, LLC. She is a public health specialist, emergency veterinarian, freelance writer, consultant, and researcher. A 2005 graduate of the University of Pennsylvania School of Veterinary Medicine and a 2019 MPH graduate of the University of Florida, she is certified in public health and passionate about One Health issues spanning human, animal, and environmental health. Dr. Tremuta-Drobness works part-time as an emergency clinician caring for dogs, cats, and exotic pets with expertise in infectious and zoonotic disease prevention, antimicrobial stewardship, pain management, and emergency and critical care. She also contributes to veterinary and public health through writing, research, consulting, and professional organizations. She serves on the board of the American Association of Food Safety and Public Health Veterinarians and is president-elect of the Evidence-Based Veterinary Medical Association. A frequent contributor to Veterinary Practice News and VPN Plus, she has authored numerous academic publications and welcomes opportunities for collaboration. She plans to sit for the ACVPM board certification exam in June of 2027. Outside of veterinary medicine and public health, she enjoys Tai Chi, cooperative care training, reading, and spending time with her husband, Scott. Dr. Tremuta-Drobness lives in Zionsville, Pennsylvania. So welcome.
Hey everyone, thank you for having me. I'm going to turn my camera off just because we may have storms, so it may help my internet. So as he said, I'm Erica Tremuta-Drobness. We're going to talk about One Health and antimicrobial stewardship today. Why are we talking about that? Well, I'm likely preaching to the choir, but among the many subjects I'm fervent about, One Health, antimicrobial stewardship, and antimicrobial resistance kind of hold a special significance for me. As a veterinarian and a public health professional, I'm accountable to my individual patients, my profession, and the global health community to implement evidence-based medicine and ensure my practices protect animal, public, and environmental health. I believe it is my obligation to utilize antimicrobials and other drugs judiciously, carefully, and most importantly, appropriately. To implement antimicrobial stewardship effectively, I must have a comprehensive understanding of medication classifications and their respective indications for use. I consistently review guidelines and recommendations from expert organizations on specific illnesses and drug selection. Furthermore, I must understand the illnesses I'm addressing and stay informed about the latest therapies and findings that support or contradict treatment approaches. Excuse me. So today I'm going to discuss One Health and the relevance it plays in the day-to-day practice, as well as the global picture. I hope to help explain why vets in practice need to make clinical decisions with the bigger picture in mind. I will then address proper antimicrobial stewardship and what that means and why it matters, including references and information pertaining to human antimicrobial categorizations. I will discuss specific drug classes based on the WHO or World Health Organization and the World Organization of Animal Health classifications of use, focusing on those that should be preserved, used, and also discuss as well those that should be reserved for last resort and only when culture is indicated and why. Additionally, we will discuss the AWARE classification and the European Medicine Agency's categorization scheme as well, something that Antec now uses for their culture results. So what is One Health? Let me get that out of the way. So what is One Health? Simply put, One Health encompasses all stakeholders in human, animal, and environmental health at all levels, local to globally, to achieve a healthy, sustainable quality of life for all. This means that everyone from those in the small animal sector to the agriculture, aquaculture, crop sectors, to human pelvic health, private practice physicians, landscape artists, landscape architects, common spaces to corporations, epidemiologists, research, and so many more all work together to achieve a globally healthy society. But what is antimicrobial stewardship? Well, antimicrobial stewardship is defined by the AVMA as basically the collaborative endeavors of veterinarians to maintain the effectiveness and availability of antimicrobial agents. Meticulous oversight and judicious decision making is necessary to safeguard the health of the environment, animal, and people. Part of antimicrobial stewardship includes understanding the various drug classes and their mechanisms of action, knowing which organisms are best targeted by what antimicrobial, a medication's role in human medicine, such as the HCIPA and various classifications we're going to go over soon, the role in animal medicine, so is it food animal, non-food animal, on-label use, off-label use, what about compounding, and their contributions to AMR or antimicrobial resistance. Clinical indications ideally should be based on sound medical evidence-based practices when available, not just because you've been doing it for 20 years and no one sued you yet. Also knowing when to use a drug and when not to, so we don't always need to reach for a drug. Judicious use of these medications supports One Health efforts for all generations, species, and the planet. So why do veterinarians have to practice proper antimicrobial stewardship? As vets, we should remain up to date on current recommendations. Understand the various diseases and what the therapies work and when, understanding mechanism of action, drug classes, uses, and indications. Again, why do we have a duty to practice proper stewardship? The nature of antimicrobial stewardship and the key public health concern of AMR clearly impacts veterinarians, physicians, dentists, and other prescribers of antimicrobials, as well as the food and production industries, among others. Vets, we need to be part of the solution, not the problem. Ensuring vets remain up to date on the latest guidelines and recommendations for antimicrobial selection, duration of use, and the first choice empirics is paramount to improving outcomes in animals, minimizing our footprint on the ecosystem, and preventing negative impacts globally. The first step in ensuring proper antimicrobial use is understanding how antimicrobials are categorized for appropriate use in people and animals. We can improve our understanding and minimize inappropriate use by recognizing these categorizations. We are all key players in the One Health arena, and our actions can have downstream effects that we must consider. So antimicrobial resistance, or AMR, is one of the most top 10, it's actually one of the top 10 global public health concerns. It is an immediate threat to both public health and safety. In the US alone, over 2.8 million resistant infections occur annually, with greater than 35,000 deaths, and that's as of 2019. The data hasn't fully come out for more recent data, but we can only assume it's worse. And AMR has been considered for contributing to at least 5 million deaths globally. Why do we care? A single dose of antibiotics could trigger resistance in a single individual. That individual could pass on that bacteria, for example, a commensal enteric bug, shed in the feces, to the environment, other animals, or people. All right, so one of the first classification schemes we're going to talk about is the WHO, or World Health Organization's list of medically important antimicrobials. They developed this as a risk management tool for mitigating antimicrobial resistance due to non-human use. It was developed in 2024 and was based on the original critically important antimicrobial list for human medicine. It was developed to assist those with authority in public health and animal health, regulators, vets, veterinary paraprofessionals, aquatic animal, plant, and crop health specialists, doctors, prescribers, additional prescribers of antimicrobials, and stakeholders in identifying which antimicrobials utilized in non-human sectors pose a higher risk to human populations. Further, the goal was to set strategies for managing antimicrobial use to reduce medically significant AMR. They classify antimicrobial categories approved for use for humans, those permitted for both humans and animals, and those not approved for humans, based on their significance in human medicine, while also evaluating their potential risk associated with the emergence and dissemination of AMR. It provides support in managing risks associated with antimicrobial use and AMR in the non-human sectors. So non-human use is defined as the use of antimicrobials within a One Health framework. It includes crops, animals, plants, and the environment. Because most of the data, however, available usually refers to that of animals alone, the principles could still be applied to crops and other uses of this drug. The focus to date, however, has been on animal-related use and primarily more a focus on food animals. However, the recognition exists that all animal use could pose a significant threat to AMR. Thus, appropriate stewardship practices are warranted when evaluating medications for non-human use, and they recognize and utilize information pertaining to the use of the drug as a treatment, a control, a prevention, or in growth promotion, although we are definitely moving away from growth promotion, thankfully. The ultimate goal for human and non-human use alike is ultimately to minimize the risks of AMR and practice sound stewardship practices. So this is our classification scheme. It is, again, used to classify antimicrobial categories based on those approved for use only in humans, those in animals and humans, and those not approved for use in humans. And again, it's based on their significance in human medicine, taking into account their AMR risks potentially. In this list, drugs are prioritized based on their class and categorized into 3 groups. Those authorized for use in humans, as you can see in black, those authorized for use in animals and humans, that's the section with the 4 colors, the HPCI, CIA, HIA, and IA, which we'll go over shortly. Medically important, and the not medically important. So the group in the middle is considered important, medically important. The group on the right is really more authorized for use in animals, not necessarily not medically important. They're medically important, just the data isn't there for humans, or they're considered low AMR risk. So as I described earlier, we have the kind of both human and animal medications are grouped into these 4 categories. We have the highest priority critically important antimicrobials, highly important antimicrobials, and important antimicrobials, and then again those that are authorized for use either in humans or just in animals. Examples of those considered for HPCIA or the top tier include most third and fourth generation cephalosporins. So if you're a prescribing vet, think about cefpiroxime or Convenia. While Convenia is an animal drug only currently, it is still a fourth or third generation cephalosporin and therefore needs to be thought of in this category. And these two drugs are very commonly prescribed by private practitioners as first line. And based on this kind of understanding of antimicrobials and the risk for AMR, they should be reserved. This category says that due to resistance risks and their use in humans as a drug class, their use should be limited and used with caution. Additional examples include fluoroquinolones, including enrofloxacin, ciprofloxacin, ofloxacin, orbifloxacin, and pradofloxacin. Again, you should be considered with clinical indication, the bacteria of concern, availability of other treatment options, and more. Further examples include polymyxin B, although we don't tend to use that often in veterinary medicine. All of these drugs have specific indications, the human versions, of course, for use with MDR, multi-drug resistant organisms, and that is their most common use, and they're usually reserved only if there's no other treatment available. Next, we have those considered CIA or critically important antimicrobials. These include our aminoglycosides, our antimycins like rifamycin, and our macrolides, including azithromycin, erythromycin, and tylosin. So azithromycin isn't one we just want to give to every upper respiratory cat if you look at how it's classified. Specific indications of use for these types of drugs are provided in humans. One or more of these drugs are classified as either watch or reserve in the WHO's aware list, which we will discuss shortly. Next, we have those that are considered highly important. These include our amphenicols like chloramphenicol and fluoramphenicol, our first and second generation cephalosporins, our lincosamides like clindamycin, drugs like metronidazole, most penicillins, and those with beta-lactamase inhibitors. Our sulfonamides and potentiated sulfonamides also fit here, as do the tetracyclines. However, a recommendation to bump the tetracyclines up to critical is made for countries with animal to human brucellosis transmission. Finally, we have the important antimicrobials. That covers the remaining drugs, such as the nitrofurantoin derivatives. And then we do have examples of drugs not approved for use in humans, like the ionophores. So now we move on to the World Health, or the World Organization of Animal Health, previously known as the OIE. Sorry, I'm trying to get rid of that. And their scheme or schematic is based on individual drugs and overall significance for human medicine. They consider the risk of AMR as well as potential human health implications associated with their use within the veterinary setting. The list covers medications that may or may not be available globally. They have statements about extra label or off label use, and that legally will vary across both nations as well as at state and local levels. The classifications of antibiotic groups are generalizations, although they do put some specific medications or subclasses listed as critically important for certain diseases. So these are the animal side's grouped into three categories: the VCIAs, or veterinary critically important antimicrobials. These should not be used for disease prevention as a first line unless justified, and if used as a second line, should be based on culture and sensitivity, are prohibited for use as growth promoters, limit extra label, off label use, and utilize it when no other alternative exists. In other words, these should be our last choice based on culture and not empirical first choices. These drugs are essential for animal health, often with very few or no alternatives available to treat serious diseases. Several of these, or many of these, do also overlap with the human medicine and human classifications, so that highly critical level, and they require strict antimicrobial stewardship. Examples in this category include aminoglycosides, fluoroquinolones, third and fourth generation cephalosporins, among others. Next, we have the veterinary highly important antimicrobial agents, or VHIAs. These are highly valuable for treating animal diseases, but there may be alternative options. The risk of AMR is present, and these can be either human or animal-only drugs. Finally, we have the very important antimicrobials, or VIAs. These are used in veterinary medicine but are not considered critical or highly important, and there are stringent criteria for which that is determined that is beyond the scope of the lecture. They're either not considered highly important in human medicine or have a low risk or a lower risk of AMR. Okay. Next, we're going to talk about the WHO's WOAH classification for antibiotics. This was established in 2017 by the WHO Expert Committee on Selection and Use of Essential Medicines to facilitate antimicrobial stewardship initiatives at all levels, globally down to locally. It was developed to support human access and improve policy on stewardship guidelines in human medicine. So antibiotics here are categorized into three groups: access, watch, and reserve, again, based on their effects on AMR, highlighting the necessity for their judicious application. And this list is reviewed and updated every 2 years as warranted. This categorization serves as a means to track antibiotic use, develop objectives, and evaluate the impact of stewardship strategies aimed at enhancing antibiotic utilization and mitigating antimicrobial resistance. So access refers to drugs that are generally considered to have a narrow spectrum of action with low AMR risk, as well as being generally reasonably priced and accessible. So these should be our first line. Watch are the more broad spectrum drugs reserved for more serious infections of concern, tend to be a little bit more costly, and have a higher level of AMR risk. And then finally, reserve are those drugs that should be used for last case scenarios, including for multi-drug resistant concerns. Okay. So next we have the EMA, or the European Medicine Agency's categorizations of antibiotics for use in animals for prudent and responsible use. These are categorized based on the potential consequences to public health of increased AMR when used in animals and the need for their use in veterinary medicine. It's recommended to review this categorization before prescribing. I think I mentioned it earlier, but Antech actually now uses this scheme on their culture results. So if you happen to use Antech Laboratories and you get a urine culture, for example, along the right-hand side for each drug, it will have one of these. It'll say avoid, restrict, caution, or prudent. And that's telling you along with whether it's resistant or not, it's telling you which of these drugs you should kind of look to first. So if all of the drugs are resistant except for the avoid, then maybe you'll go to avoid. But if the prudent or category D is available, then that should be your first line choice. So our category A are avoid, that one at least makes sense, not authorized for veterinary use in the EU, thus should be highly avoided in the US. They are not to be used for food animals, and with exception, may be used in companions as a last resort. Category B are the restricted, critically important human medications. They should be used minimally to lessen the risk of AMR and public health impacts, and only used when category C and D are not feasible. Category C is used with caution, again, only when no antibiotics in category D are an option. These also will have alternatives in human medicine. And then finally, we have category D, or prudence, our first line therapies, but again, still only when medically necessary. So One Health has a 10-20-30 target against AMR. Mendelssohn et al. Suggested that sustainable access to effective antibiotics be presented to the UN General Assembly. The goal for a global decrease in AMR was arbitrarily, basically, but set for 2030, and it was known as the 10-20-30 target. The goal was to reduce the rate of AMR, a 10% decrease in deaths, a 20% decrease in improper human antimicrobial use, and a 30% reduction in improper use in animals by 2030. Unfortunately, we're probably not going to get there. Note that the research and recommendations here focus on bacterial resistance alone and thus likely underrepresent the burden and risks. In a more recent Lancet article, numerous professionals report that they suspect that they were unlikely to achieve this goal by 2030 and that our burden through 2050 will be much higher than estimated. Still, for bacterial resistance alone, the forecast by 2050 is that 1.2 million global deaths a year will be attributed to AMR, and up to 8.22 will be associated with AMR. Kind of a scary thought. So we're going to change gears a little bit and talk more about prescribing antimicrobials and things to think about. This is a great document by the World Small Animal Veterinary Association. You can download the PDF. It's called The 6 Moments of Veterinary Antimicrobial Prescribing, although I add a seventh that we'll talk about at the end. But it's a great way to kind of think about a diagnosis, think about your options, and think about what you need to do to treat and help that animal or group of animals. So you want to think about, okay, well, let's start with my diagnosis. What is the chance that this condition and clinical signs in front of you are going to represent a microbial infection? We want to consider our history, our PE findings. Depending on the system of concern, for example, like if it's skin or an abscess, we may want to do cytology or submit for culture and sensitivity. Next, we think about treatments. Are antimicrobials even warranted? What non-antimicrobial options for treatment are available? Consider acute diarrheal diseases and viral infections in cats. We can consider fluids, nonsteroidal anti-inflammatories for viral infections, not for diarrhea. Nutritional changes. If it's a GI foreign body, let's remove the foreign body. Probiotics. If it's a wound, draining or lancing the wound, or watchful waiting, something we'll talk about soon. Guidelines. So there's actually a PDF. In this PDF, there's actually a QR code to several guidelines, which I think I discussed many of them later, but to multiple guidelines that do that are varying degrees of evidence based on antimicrobial recommendations for specific conditions. So that's something that definitely want to avail yourself of, and you want to review the guidelines that are out there. Veterinary medicine really does lag behind human medicine, and we definitely are lacking studies that really tell us clear-cut directions on duration of treatment and, specific drugs and recommendations, but there are some out there, so it's definitely worth looking for them. Next, we want to consider our antimicrobial selection. So what is the most appropriate drug to choose if we need an antimicrobial? We have to use proper antimicrobial stewardship, and we have to consider the following: products available to us, the efficacy of the medication at the target location. Is that drug going to penetrate the urine? Will it penetrate the abscess? Will it penetrate the lungs? Public health critical importance rating, as we discussed earlier, so all of those various categorizations, the route of drug administration, drug side effects, medication interactions, and even previous exposures to other antimicrobials. If a patient has been on numerous drugs already, do we want to add yet another type or class, which could increase the risk of AMR in that patient as well as disrupt their microbiome? Owner education or advice to these owners. We deal with people a lot in our profession, contrary to what popular belief seems to think. We need to ensure we manage client expectations, reassess patients, and recheck with clear instructions, providing any additional advice whenever warranted. We want to manage expectations. We need to explain treatment options, discuss expected responses. It's always fun when you send a client home with a probiotic and a bland diet, and they call 6 hours later panicking because their dog still has diarrhea. We need to provide them with clear-cut, when feasible, reasonable expectations. Advise owners what to look for. That's suggesting a problem or failure of therapy, if there's worsening clinical signs, or when something could be considered a true emergency. Plan rechecks or reassessment. Set a recheck appointment, or if you're like me and work in an emergency setting, in written discharges clearly indicate when, if necessary, they should follow up with their primary care, specialty service, or if it's not needed. You can also consider other advice. So if appropriate, emphasize the benefits of nutrition is always helpful, even if it's just a simple comment to ensure the pet is eating. If you do send home an antibiotic, owners should be properly informed that antibiotics can disrupt the microbiome and can cause GI upset, including vomiting, diarrhea, and anorexia. They should also be advised to notify the vet if any of these signs are observed. If the pet isn't eating for 12 to 24 hours, depending on the situation, patient age, and species, this could be serious and a recheck may be needed. Consider mentioning vaccinations if appropriate or overdue, but also educate that they should be administered after the patient has recovered to ensure a proper immune response. Please do not give vaccines to pets when they present with illness. If you determine an infection is present and prescribe an antibiotic, this isn't the time for vaccinations. Next thing to consider is our dose regimen. So dose regimen includes the drug formulation, the dose, the route of administration, the frequency, and the duration of therapy. Many factors influence these decisions, including our clients' adherence abilities. For example, I recently lost a dog too soon, but she was on medication initially 4 times a day for most of her life and 6 times daily near the end. This often dictated my schedule and was challenging. So we need to consider the owner's schedule, their physical abilities, and the patient's disposition when choosing meds. If the patient doesn't have a sensitive stomach, will they only take liquid or pills? That's something else we need to consider. And then finally, I know there's only six, but I added the watchful waiting or the kind of the seventh um, concept because I think we need to do this more often. Watchful waiting is when we as vets stay vigilant. In cases where antibiotics might be needed in the future, but where we expect the condition will resolve on its own or with supportive care only, we inform owners carefully so that they know how to recheck and when, and give them methods for symptomatic and comfort care. Owners often expect dosing antibiotics, some type of medication, and they want something tangible to treat their pet. They often don't want to go home empty-handed, so to speak. However, we don't prescribe antibiotics or antimicrobials to appease the client. We only prescribe them if they are truly wanted. An example would be a dog with acute diarrhea who's BAR, eating, and can be treated with probiotics and diet alone. Stress to owners: no treats, no dog chews. Ensure they stick to the bland diet and only use the bland diet to give the medication. Um, Educate owners on the time it takes to respond. So, your average acute diarrhea can take 3 to 7 days to resolve, even with management. And so, owners need to be patient. Um, Another example would be watchful waiting with our healthy, I say healthy in quotes, our bright and alert feline upper respiratory infections. You may choose to do an antiviral depending on severity, but if they're eating, otherwise bright and alert, afebrile, it's viral. We usually give them 10 days. And if they're not improving or worsening, they're not eating, they become febrile, then we can reevaluate them. But most of the cases, in those cases, watchful waiting is all that's necessary. We don't treat human viral infections with antibiotics either. So it kind of makes sense. So that's something to consider when you're prescribing. So the agricultural sector in Victoria, Australia uses this catchy phrase, stop, think, and choose wisely. They state that not all bugs need drugs, which is so true, and we need to educate clients to that fact as well so that they understand why we're not always prescribing. So the World Small Animal Veterinary Association aims to minimize resistance. They suggest as a guide that if two medications are equivocal in their effectiveness and treatment for condition A, then we are to select the drug which has the lower chance of inducing an AMR phenotype. We are then to avoid those drugs classified by the WHO as high priority, critically important for use in human medicine. So this is the third and fourth generation cephalosporins, the fluoroquinolones, again, unless it's clinically indicated either by culture or otherwise. And this is based on recommendations that rank these medications for their use in non-human use, as we've already discussed. So an antibiogram constitutes the aggregated antimicrobial susceptibility test, or AST, results for a specified antimicrobial drug, bacterial species, animal host combination across a designated time frame, for example, 6 months, and a population subset, for example, a geographical area, a farm, or a vet clinic. Compare this to a single AST like your culture on a specific patient. These represent isolates from a group of animals at a specific site or with a specific health problem. For interpretation, it's suggested that a minimum of 30 samples is necessary. Breakpoints are then established by the Clinical Laboratory Sciences Institute. They are then utilized in human and animal labs. Further, cumulative data helps determine breakpoints for susceptible, intermediate, and resistant organisms. Why does this matter? Well, ideally, we should use these for local regions and specific diseases, for example, respiratory or urinary tract isolates, to help guide antimicrobial choices. An example of this would be in California, a lot of the urinary tract infections in dogs are resistant to clavamox. Not necessarily your first line drug anyway, but were it a first line drug or even a second line drug, if you use it, if they have already got established resistance, then it's not going to do your patient any good, can only worsen their own risk of AMR, and isn't going to help that patient. So knowing what locally those ASTs look like can help guide some of your antimicrobial choices. More studies in the animal realm, however, are truly needed to permit this type of use for everyday decision making. A study by Lorenz et al. In 2023 in California livestock demonstrated the development of these as a tool for One Health antimicrobial stewardship, and it works well in various settings. Reviewing how to use these in clinical setting is beyond the parameters of this talk, but current research suggests that on-site surveillance on clinics, on farms, or in other scenarios, and ongoing assessment of both antimicrobial utilization and AMR should be implemented even at the clinical level, as this can help curb our antimicrobial use and improve stewardship. So I've touched base on the guidelines that are out there. There are numerous guidelines out there that talk about various antimicrobial usage. There are varying degrees of evidence-based, so some are more evidence-based than others. Some have a more general principle discussion, while others will focus on key topics, including treatment of diarrhea, respiratory conditions, urinary tract disease, and skin. Several are formulated by groups of key individuals using systematic reviews and meta-analyses, when feasible, of the literature, clinical experience and practices, antimicrobial susceptibility profiles in various regions, risks of AMR, and other factors. There is so much literature out there, and it can be several classes in and of itself on how to evaluate the literature for accuracy, generalizability, bias, true evidence base, and the factual nature of the evidence. Thus, having the material synthesized for us in practice is great. They're often updated regularly to reflect new findings and recommendations. Be aware, however, that just because it says guidelines doesn't mean that it's truly evidence-based review. For example, I know that the AHA guidelines are actually not evidence-based. They're peer and opinion-based, or expert opinion-based, which doesn't negate their value, but can lead to some improper conclusions based on current evidence. So just keep that in mind when you're reviewing these. But these guidelines are worth checking out. Here's some more, both guidelines as well as for specific diseases, as well as, for example, the University of Minnesota has a stewardship and antimicrobial resistance kind of website, which is also very helpful. That site also has educational webinars and modules on AMR and stewardship that can be worth checking out. Some additional references and quick glance aids include when antimicrobial susceptibility to testing is recommended in cats and dogs by the AVMA, how to use a clinical antibiogram, antibiotic use in companion animal veterinary practice by the U of Minnesota. There's a good handout on why not all bugs need drugs from the Agricultural Victoria in Australia, with one side showing that if a pet is started on antibiotics, why and what that means, versus if not. The AVMA also has a couple handouts and charts. Does this dog need antibiotics? There's a chart for vets with a companion handout for clients. There's also a one for cats. Again, does this cat need antibiotics? Mimicking the dog handout for both vets and clients. There's a prescription pocket guide, antimicrobial prescribing for small animal diseases by the University of Minnesota that has a few clinical diseases. And it was written a few years ago, so it might not take into account the WOAH and WHO's most recent changes, but it's still a good place to start. And then finally, the Federation of European Companion Animal Veterinary Associations has a chart for recommended appropriate therapies for use, including what to avoid for empirical therapy. It too is a little outdated at 2018, but it shows kind of the types of things you want to ask yourself when selecting drugs. So how are we doing as a profession? When I searched, despite my recent work on One Health and AMR stewardship, I found even more resources than the last time when I wrote about this topic earlier in the year. More information is becoming available. You just have to look. Additionally, we need to implement many recommendations, as current research, though limited, suggests. Surveys show that a large percentage of vets are aware of available guidelines for common conditions like pyoderma and lower urinary tract disease. However, when it comes to selecting antimicrobials and treatment durations, many still default to what we've used for years rather than stepping back to ask, is Clavamox really necessary when amoxicillin would suffice? Do I really need to treat a simple UTI for 2 weeks, or can I go with 3 to 5 days as current recommendations suggest? Ultimately, it is hard to quantify how much veterinary medicine truly contributes to AMR globally. However, we do contribute if we select antimicrobials without thought and judicious use. Further, we are likely doing harm to numerous patients. Antimicrobials negatively impact the microbiome, even with a single dose. They are not benign. We may induce resistance within individual animals with a course of antimicrobials. Thus, One Health issues aside, we could be doing our patient more harm than good, which goes against our oath as veterinarians. Excuse me. By considering the One Health ramifications as well, we're doing an injustice to individual and collective animals, the environment, our clients, and it could have potential global ramifications in the future. Thus, let's be judicious now. A recent study reported in JAVMA in January 2025 by Granick et al. Measured antibiotic use in dogs and cats in both primary and referral practices in the U.S. to glean stewardship insights. 52 practices and a total of 2,599 records, dogs and cats, were evaluated. They reported that 478 patients were prescribed antibiotics with the intent to treat actual infection, and only 13.4% had culture and susceptibility testing. Further, third generation cephalosporins were often first used as first line therapy, and as they are considered highly important, critically important class of drugs, should be based on culture and not empiric use. Two other things stood out from the study: the overwhelming use of metronidazole in the treatment of acute diarrheal diseases. Numerous studies, including a recent systematic review, have shown that metron negatively impacts the microbiome, does not result in shorter response to therapy, and that diet alone or diet with probiotics is superior to metronidazole in the treatment of acute diarrhea. Secondly, current literature does not support the use of antibiotics for clean surgeries, yet this study observed a high percentage of antibiotics used for these procedures, with treatment durations extending beyond just perioperative periods, sometimes as long as we treat actual infections or underlying conditions. When proper aseptic techniques are followed, the use of peri and post-procedure antibiotics is not necessary. Human studies strongly support this approach, and although veterinary literature is still lacking, efforts are underway to fill this gap. Orthopedic surgeries have established guidelines, but other procedures still need clearer recommendations. Excuse me. So, before reaching for an antimicrobial, always ask yourself, what is the smallest gun with the least impact on the human field and AMR? Are you reaching for a critically important medication in human medicine? And if so, can you justify your use of that therapy? Have you tried topical applications before reaching for orals with localized skin infections, for example? Are you basing your decision on culture and sensitivity? Are too few people in your practice doing cultures? Perhaps revisiting your fee scale may help with that. All too often, I work at practices where across the board lab tests are 1.5 to 3 times the practice cost. That's great if the tests say costs 20 to 50 bucks, but cultures should be priced so that the majority of people would at least consider them. Owners often do not understand the importance of preserving antimicrobial use. Therefore, we must educate them on the benefits of culture and the negative impacts of starting antimicrobials prematurely, which can harm the GI flora and the pet's overall immune health. Remember, practicing proper antimicrobial stewardship includes understanding the disease you are treating and common etiologies, knowing the first, second, and third line treatment options, understanding drug mechanisms of action, dose ranges, frequency of administration, drug interactions, and side effects. We must evaluate each patient as an individual. We should be using evidence-based recommendations when available and always stay current. Evidence improves and things change. I must have talked really fast because that was not quite as long as I expected. If there are any questions, I'm happy to take them. And thank you for your time.
Okay, thank you, Dr. Tremuta-Drobnis. We will have time for questions. So if you have any of our speaker today, please type them into the Q&A feature of Zoom. I'm going to let her take a short break while I repeat some of the administrative announcements. First of all, CE certificates, again, we will get those out in approximately a week. Please, if you dialed in with a telephone, and I'm seeing about 6 people that did, please email me at EVP, that's E as in Eric, V as in Victor, P as in Paul, at acvpm.org. And let me know your name and the telephone number you use. That way we can link your name with an attendee. This session is being recorded. We do post all of our webinar recordings to the ACVPM YouTube page. So if you want to go back and catch anything you may have missed or want to share it with a colleague, please go to the ACVPM YouTube page in approximately 1 week. Okay, we do have a few questions. I will present those to Erica today. First question is, the FDA has its own list of medically important antimicrobials, which differs from the WHO classifications. How do these lists intersect for veterinarians located and regulated in the United States?
Say the last part again.
How do these lists intersect for veterinarians located and regulated in the United States?
Okay. I honestly would have to go review the FDA one. It's been a while since I looked at it. The WHO list is from the human perspective. The FDA list looks at it from, especially the food animal side, looks at it from a drug residue situation, looks at it from um, um, from their ability the approval side. Um, Unfortunately, I don't think they communicate together enough. There should be more coordination between these lists, but the WOAH and the WHO are also global, whereas the FDA is only the US. In some ways, I think that the FDA list um, kind of falls in between the global lists because it is again just taking into account the drugs that are used in the US most of the time. Um, I would have to look, honestly, from a regulated standpoint, I'd have to go look at the FDA list again to see if regulation wise what it entails. So I apologize, I don't have that answer all the way.
Okay. The next question is, of the 5 guidelines you listed, how much duplication is there? And importantly, are there any major differences in their recommendations for certain antibiotics?
Um, so the European list, it depends which list we're looking at, and I can bring that up. Hold on. Some of the lists have specific recommendations for drugs, so or for conditions. So, for example, the iSCAD one has actual recommendations for specific urinary tract skin. I will say that that one is not as evidence-based as they wish it were. There is talk that they are going to review those and actually do a more evidence-based systematic review of those. And those guidelines actually are a few years old at this point and due to be revised. But they do have some specifics about duration of treatment, specific first line drugs for example, urinary and pyoderma. World Small Animal Veterinary Association, again, unfortunately, does not always do systematic reviews to come about their recommendations, and their recommendations are at a global level. Inovat is a very well evidence-based organization. They do true systematic reviews to come to their determinations. It is European, so it does not include some of the drugs we have in the US, or the names of the drugs or classes are a little different. Australia's, I believe, is also evidence-based. There is some overlap in terms of recommendations, and some of them are older than others. So some of it you kind of want to look at the newer ones, which of those I would say Inovat would be the most evidence-based and the newest at this point. But again, we're still really lacking, unfortunately, in general in veterinary medicine, in a lot of the studies that show duration of use for some of these conditions. So I know there's been a recent one come out about pneumonias and urinary tract stuff, and it's still not very clear how long do we treat, how high of a dose, what dose, even dose ranges are still in question. So Unfortunately, we still need a lot more evidence, but I would say going to one of those, especially the INNOVAT for um, evidence-based information is very important. Hopefully that answers that.
All right. The next question is there any data or information regarding the impact of over-the-counter availability of antibiotics in other countries such as Mexico?
I don't know. I haven't looked. My guess is that they probably can't track that very well because there's not, I don't think they actually report the use of those drugs. And it's not just in Canada or in Mexico. A lot of countries have over-the-counter use of antibiotics. Um, I do know that when the FDA made the rule that they stopped selling some of the antibiotics over the counter in feed stores and for large animal, that they did appreciate a decrease in consumption or in purchasing at least of those drugs. So it did make some type of an impact. Excuse me. I don't think they can measure that easily on the human side or animal side in some of these countries where they are legal over the counter, unfortunately.
All right. Do you have any comments on the food animal residue avoidance data bank, its usage and the benefits?
I am a small animal vet, so I don't know the nuances of it. I do feel that it's important. Um, I I don't know. Unfortunately, the funding has decreased for it, and so I know that the government is actively looking to try and fund more for it. Um, but it's also got voluntary reporting. Um, I think it's important from the standpoint of monitoring what goes into our food system. But I think we have a lot of room for improvement for monitoring not just antimicrobial drug residues, but all drug residues and drugs in general.
All right. Next question is regarding the slide related to the 10-20-30.
Mhm.
What is the scientific basis for reduction targets around antimicrobial use, particularly in the animal health space? Should not the focus be on increasing stewardship and not on arbitrary targets?
Um, I honestly, I haven't read the paper recently. I'd have to go back to see what their actual reasoning for those specific targets, why they chose that versus um, improving antimicrobial use or stewardship. But the implication or the um, means in which to reduce those was by improving stewardship. So the through improving stewardship practices, especially on the animal side, um, the thought was that by improving those stewardship practices, that's how we would reduce improper use. So while the targets are based on a decrease in use, um, stewardship practices and improving those practices would ultimately impact use, if that makes sense.
All right. Um, a kind of a comment and a question. Thanks for your excellent presentation. As you mentioned, selecting the appropriate antimicrobial treatment includes concerns for owners' understanding and compliance. We tend to choose the once a day or longer acting extended release antimicrobial for owner convenience, which may be one of the more restricted or critical listed antibiotics or antimicrobials. I'm sorry.
Mhm.
Could you comment on how to resolve this conundrum? And then a PS, very nice to see a former VMAT2 member.
Oh, hello. Um, so it's actually one of my frustrations because I get it, especially when you're talking about, I'm assuming we're talking about convenia, for example. So for those that aren't necessarily in small animal practice, convenia is cefepozin, which is a third generation cephalosporin. It is a depot med, so it is a sub-Q injection that lasts up 14 days or more within the tissues. It is labeled for abscesses and skin conditions primarily, but is used across the board in cats a lot, dogs sometimes, smaller dogs sometimes. Um, and I find that people automatically give it to cats for almost any condition because they're like, oh, owners can't medicate, but they don't bother to even ask. So I think part of it is we need to educate owners on, can they medicate? Are they comfortable medicating? Teach them how to medicate properly and choose a drug that's appropriate for the condition at use. While yes, considering convenience, considering if they're going to compliance is important. If we don't give them the option of the injectable that's going to last 2 weeks, they're not going to necessarily know it's there. But if you give them the option of, we can do a treat, we can do a liquid, we can do a pill, what would you be able to give? Is once a day, twice a day better? Then we give the owner an ability to give us what works for them, but within the confines of appropriate use. So we're not selecting a drug that's improper simply because we're assuming the owner can't medicate, or that it's a cat, so we have to give the injectable. Um, sure, if it's an outdoor only cat that they're not going to be able to catch every single day to give meds, is giving sevoflurane better than giving nothing? Probably, especially if it's cat abscess. But if you take a look at the broader picture, are we doing more harm? People that are prescribing Simplicef or cefpiroxime, which is a once a day third generation cephalosporin, are doing their animals a disservice and are using improper antimicrobial use just for convenience. And so, could you be reaching for clindamycin or another drug that is lower on the classification schemes, both in humans and animals, that might have to be given twice a day as opposed to once a day? Are we doing more harm than good? Again, working with the owners, making sure that they can give something twice a day, which is obviously easier for dogs than cats a lot of the times. But working within those confines of still, giving the owners some choice and some ability to tell you what works with their schedule, what's feasible, but also you don't need to offer them the injectable if it's not the right time or place for it. So if there's another option that is better, that's not going to risk AMR, then that's what we should be using.
Okay, very, very good explanation. One more question. What are your recommendations with regard to AMR, AMS, and infection prevention and control plans for veterinary clinics and hospitals?
Wow, that's a loaded question.
That's a big one, yeah.
Um, so I do find that a lot of practices don't even have infection control programs. Um, so having an infection control program in and of itself is ideal. Um, I would say as part of those infection control programs, there should be antimicrobial stewardship practices in place. That I'm not a fan of like cookie cutter medicine, so I don't want to say have specific drugs and specific, conditions and list everything that you're allowed to treat it with, because I don't feel like that's the right way to practice medicine. But on the other hand, there should be some stipulation as to, which classes of drugs should be appropriate to use as empiric therapy, you know, when it's appropriate to culture, when it's appropriate to treat with a more higher risk drug. Um, and that should go along. So I'm a emergency clinic and work at 24-hour practices. So that should also be in place for injectable choices as well. So, not reaching for the big guns injectably just because you have them, but starting with the lower guns and then adding as you need or as clinical cases dictate. Um, and I think that incorporating antimicrobial stewardship into your infection control plan should helpfully improve at least clinical cases as well as the clinic's risk um, for contributing to AMR at least.
Okay, kind of a follow on, I guess this is of the resources that you provided, are there any template plans or programs out there for
Not that I
practice?
provided, no, but if you actually look, there are several universities, I think, actually have infection control plan templates. Actually, just download and fill in. And they have outlined guidelines of things that you need to look at, things that you need to incorporate into your infection control plan, things like an isolation ward, things like, you know, what types of PPE or personal protective equipment you need for those isolation units and specific diseases, whether it be parvo, whether it be panleuk, whether it be upper respiratory type stuff, lepto as well. And then, they'll all, I've looked recently too, and I apologize, I don't remember what, but several universities and probably several private organizations actually have templates for those.
Okay. Well, in today's world, you can probably just type it into Chat GPT and
That
get
too,
get get
although,
get a good start point.
yeah,
Okay. Um, all right. I think we're going to go ahead and close the questions at this time. Definitely appreciate the engagement by our attendees. And I want to thank you, Dr. Tremuta Drobnis, for your presentation,
thank you for
for
having me.
spending your time with us today. It was a very informative presentation, well represented or well attended by our attendees. I'm seeing a lot of clapping hands going up, so they appreciate your time also.
Thank you.
We can't do it without volunteers such as Erica. So I encourage everyone to consider either presenting themselves or nominating someone that you think would give a good presentation during our one of our webinars. You can either email me at evp@acvpm.org or on our website, the ACVPM website, under the continuing education tab, there is a way to self-nominate yourself to present. We definitely, again, can't do it without volunteers, and we do appreciate your support. So our next CE webinar, it will be held on the 14th of September. And I neglected to write down the topic, so it will be a surprise when the invitation's already out, but I did not write down the topic, but it's on the 14th of September. So if you're interested, please register for that. Thank you again, Erica, for your time. Thank you for our
Welcome.
attendees, and everyone have a wonderful afternoon.
Thank you.
Thank you. Bye-bye.